Good day. We are so excited to have you join us with our webinar today, our 129th webinar in a row over almost 11 years. Today's title is Workplace Violence, a Patient and Caregiver Safety Update. I'm Charles Denham. I'll be the MC today and moderator for this webinar. I have a couple of housekeeping details, and I'm on the third slide for those that have the slides. And we just want to remind you to turn your WebEx volume up to the maximum, your computer volume to the maximum, and your external speaker volume, if you're using external speakers, to the maximum. If that doesn't work for you on your audio, on slide 4, you'll see the icon that you can click on under Participants, under the Participants panel, and click on the phone, and you can request a phone line so that you can dial in. I'm on slide 5, and for those of you that want to return to look at resources that we will continue to post on this page, go to www.safetyleaders.org. Go to the What's New upcoming events today to get the slides. In the future, there's a tab at the top of the landing page that says Webinars and Meetings. And if you click on that, that will allow you to go back and watch this webinar and be able to collect the slides and any other resources. When you do click on that, you'll be on what is on slide 6, which has the photographs of our speakers today, and we'll continue to be posting information, and this is where you'll be able to come back to watch the video of today's webinar. On slide 7 are our social media addresses. I won't read them for you, but they're on slide 7. Our purpose statement on slide 8 is, we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And this could not be more fitting than to cover the issue of workplace violence today. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and the ventures we undertake. Our disclosure statement pages on slide 9, I won't read it to you, but no product, service, or technology will be addressed today. We have never taken any funding from industry, from the device, service, or pharmaceutical industries to support these webinars. These webinars are offered free with no sponsorship. Our speakers and reactors today are on slide 10, and we're so privileged to have Richard Mereu speaking first today after I cover what's in the news. We have Vicki King recorded today, and she is the Assistant Chief of Police at MD Anderson, and we have Chief Adcox live, who is her teammate and her boss at MD Anderson. And we have Arlene Salamandro representing the voice of the patient today, and we're so grateful to have Arlene with us. Arlene is a former board member and staff coordinator for Families Advocating Injury Reduction, FAIR. She is also co-author of multiple publications as a patient advocate and has served on multiple committees. I think most importantly that Arlene was one of the patient advocate team that we worked with back when the HACs, the hospital-acquired conditions, were being proposed, and coordinated a grassroots effort to help support the HACs with an evidence-based approach that ultimately led to more than $2.9 billion saved and 8,000 lives saved. And she has particular interest in the area of bullying and workplace violence that is on the continuum from verbal to emotional to social to physical. And so we're going to ask Arlene to set our compass heading today and just represent the voice of the patient. Arlene?
Yes, thank you, Chuck. I would like to welcome everyone here today for the webinar. I think it's going to be really informative, and I'm looking forward to learning about what we could do as patients to keep ourselves and what caregivers could do to keep themselves safe in healthcare facilities. So thank you very much for having this, and I'm looking forward to what I'm going to learn. Thank you.
Fantastic. Thank you, Arlene. So I'm going to rapidly cover a news update and a webinar recap from last month so that we can move very quickly to our two speakers today. since our last webinar, for those of you that might be first-timers with us, we cover a number of topics that are in the news that might help you make your case for patient safety and quality in your organizations. And after our last webinar, it was shocking to hear that, that not only Pete Conrad died the preventable death of a systems failure, a patient safety issue, but the first man that walked on the moon also was subject to a patient safety issue. So look it up. This story will be very helpful as you make your case at your organization for patient safety and systems issues. I won't go into the detail today because we have such great speakers and I want to give them generous time, but I do want you to make sure that, that you read about this story and use this story in your arguments for patient safety and quality at your organizations. July 29th, there's also a report about how BJC cut patient safety harm by 75%. They focused on pressure ulcers, ADEs, adverse drug events, HAIs, hospital-associated infections, falls, and thromboembolisms. And so, good story. Again, we need to keep putting these stories in front of our leaders to show them the impact of what is important. The next story, August 6th, that came out was regarding the San Diego VA. And kind of highlights there is that the press, and we're not calling it either way, but the press said that the organization failed to follow rules and guidelines. I think it is so critical, so important that we keep emphasizing how system failures can happen when we have when we drift off of policies of procedures, and why it's so critical that we don't allow normalization of deviance to occur. And whether that happened here or not, the reason that we're showing this story is that it's another example of how investigative reporting is really moving into the patient safety area. Now, there were a number of other articles, and again, because I want to move quickly to our speakers, we've developed over the last 3 months an additional resources section at the end of your slide deck, and we just want to remind you to follow some of these stories. The big three misdiagnosis issues that came out from the Hopkins study, the Ohio health system firing 23 people that were thought to be enablers of fentanyl deaths, and then the Leapfrog group reporting that only a quarter of the hospitals failed to comply with their never event policy, which is critical, and a BMJ article on the prevalence and severity of preventable harm. These are all, I think, important to watch. Now, in this area of misdiagnosis, one of the articles that came up here in the last few weeks was 6 ways to lower error and unnecessary surgeries. And so make sure to take a look at this one. I'm a radiation oncologist, cross-trained in radiology, and we have always seen an enormous opportunity to close some of the gaps in radiology and in preparation for surgical procedures. This audience, our audience, has asked for and in fact demanded more and more on drug diversion. This story just hit the New England Journal of Medicine on August 6th, and it's very, very important that you read this about a nurse that used tap water to replace opioids that were being diverted for her use, as it's alleged and reported. The problem was that multiple patients got very ill, and there were deaths related to this. So 4 of the 7 syringes that had been stored in a Pyxis unit grew the pathogens that normally are found in tap water. So this is something that we need to really be aware of, and we know that drug diversion is a really critical issue. Now, you'll see in the NPR report that drug overdose deaths dipped in 2018. However, some of the states saw devastating increases. And so make sure to familiarize yourself with this if, as you are addressing opioid overdoses in your organization, and someone says, oh, well, we think that they're going down. Wait a minute, you have to look state by state. Your state may be one where they got worse. And so you've got to read past the headline. Another thing that popped up just a couple of days ago is, for the very first time, a U.S. panel is recommending, and the panel is the U.S. Preventative Services Task Force, has recommended screening adults for illicit drugs. And wherever wherever this goes, we don't know, but it's part of this opioid crisis that we're facing today. So keep your eye on it and be aware of it. Pull the article, and the reference is at the bottom of the page. But this is shocking it will be questionable how this might be implemented. So now shifting from what's been in the news to the stories that we're tracking, this is a letter that went out to a number of research organizations regarding the conflicts of interest and failure to disclose resources from other organizations and nation-state organizations. This went out to the majority of our research organizations, and almost all had specific issues. Conflicts of interest and investigative reporting is very serious, and so we're tracking a number of these stories. The Hopkins story of multiple sites in the Hopkins system where issues were identified specifically in their cardiac hospital for children, but then in their burn center and across the whole Hopkins system. And there are a number of conflict of interest stories and patient safety stories and fraud stories. Hopkins, Memorial Sloan Kettering, Baylor St. Luke's Medical Center, where their transplant system was shut down, the Brigham and Women's Hospital, where 31 articles were retracted on cardiac stem cells, Vanderbilt University, and the stories go on and on. Duke University, University of Maryland Medical Center, along with the mayor, and most recently, what has just popped up is the University of North Carolina system CEO non-disclosure of millions of dollars from industry. And so this continues to be just an evolving crisis. In our resources section, you'll see a number of the articles that you can go back to and refer to regarding healthcare and academic fraud stories. Again, we won't cover them today. We just want you to know that they're in our resource section. And we launched a program called the Healthcare Innocence Project, focused on the digital DNA, which is the new DNA of healthcare, following the same principles of the Innocence Project, where many people's convictions were reversed once the testing material of DNA had been used to identify actually who was innocent and who was not. And so this is a program that we'll be continuing to support. The second program now, just before I go over the surveys, are the MedTech program, and Chief Adcox is with us today as a co-leader of this program at MD Anderson, and we have a number of hospitals, including Mayo Clinic and a number of our top U.S. News and World Report hospitals are involved in this program. And this is pre-hospital care, leading causes of death before EMS arrives and before you get to the emergency department. A number of articles you can go to the resource section to read. I'm not going to go over them. There's a series of 3 articles. There'll be 3 more by the end of the year that we're writing on AED placement, et cetera. And also for the first-timers, you can go to YouTube and watch the briefings regarding these topics, addressing CPR, active shooter events, trauma care, and the 8 leading causes of death. Now, in the last month, and we are following stories here, dispatch-driven CPR is saving lives all over the country. So we have about 1,000 sudden cardiac arrests every day, and there is so much we can do. The survival drops 10% for every minute that we don't use CPR and AED. Coming to caregivers, one of the Modern Healthcare articles this month addressed not forgetting our caregivers after mass shootings occur. And in our MedTech program, we're deploying the Stop the Bleed program in partnership with the American College of Surgeons. Also, an epidemic of drowning this summer. No one can really explain why, but water safety is critical, and we've seen this summer a number of drownings of parents trying to save their kids. I live in Southern California. We've had just a wave of drownings here and are working in that area. So that finishes, and we're right on time now. That finishes in the news. So just a quick briefing from last month's webinar. We had the quality journey addressed by Mike Henderson, former head of quality for Cleveland Clinic and now the chief medical officer at the University of Mississippi, and Kevin Cook, his CEO. We asked if you wanted another webinar. They got 100% net promoter score, and we rarely get this high a number. We have more interest in leadership, So we'll be presenting another webinar this year with them on their 100-day projects. Go back and watch the webinar. Kevin Cook has pioneered that role of 100-day projects for mid-level managers. If you want to look at some of these leadership tools, look at last month's webinar. We ask, because this misdiagnosis issue came by without a lot of press, and so we really want to make sure that that everybody is focused on this new wave of misdiagnoses. And we ask our audience, would you like to have leaders in these studies and are knowledgeable about the misdiagnosis patient safety crisis? And you can see that we got a 58% 10 out of a net promoter score. We had neutral, but an awful lot that said that they wanted to have those covered. On slide 38, you can look at what people have asked for misdiagnosis. We'll poll the audience again. We asked last month, would you like, are you interested in this webinar for workplace violence? We've got over 400 institutions on today, this morning, so there's no question that that you showed interest there. And the topics that you see before you today on slide 40, we're covering a number of these topics with Richard Mereu and Vicki King with Chief Adcox supporting them. So let's move now to workplace violence. We're right on time. This is an article, July 19th, nurses voicing concerns. We've all heard that we have 4 to 5 times the amount of workplace violence in our sector versus other industries. As you start to put your workplace violence story together for your organization, there are a number of articles that are popping up. Just here, August 12th, 3 days ago, nurses talking about violent assaults. According to American Nursing Association, 1 out of 4 nurses are assaulted on the job. You'll hear from Richard Burrow how frequent it is in the emergency departments and how frequently this occurs to physicians as well in the emergency departments. Nurses say violent assaults against healthcare workers are a silent epidemic. This is unquestionable. I think the Me Too movement has helped spur more interest in this area to kind of pull back the curtain. Another article, and again, these are all articles in the last 30 days as an introduction to Richard Mereu and Vicki King that we've polled. And in Modern Healthcare, a very good article. We didn't summarize the whole article. Go pull it. It's got a number of graphics that you can use to help tell a story in your organization regarding the frequency. And this was a survey of nearly 1,000 participants who have experienced the various types of workplace violence. The other issue, which is pretty quiet, but we've seen with organizations we're working with right now, is the intimidation of nurses after a bad event occurs, and the bullying of nurses into changing their stories and intimidation that can occur in organizations, and how we protect against that. Confidentiality agreements have, this is an article about how it emboldens wrongdoers. Again, this is just in the last month. So each of these articles you could use to kind of expand the story, but these the non-disclosure agreements can have an enormous impact. Also, 2 days ago, an article about bullying among internal medicine residents and how frequent that this occurs. And the training directors are now starting to really identify that this is happening in our residencies, whether they're female or male, and the extent of this problem. And then finally, FedWeek last week addressed protection of employees and federal employees from workplace violence in the federal systems as well. So this is a super hot topic. August 5th, just 10 days ago, increasingly under attack, healthcare workers may wait for decades for protections, and we know that Richard Mereu will cover this. National Law Review did address Illinois enacting a workplace harassment law, so we do see some movement going on, and that gives you kind of a very quick drive-by of a number of the articles, and these are just in the last month on workplace violence, not the prior studies that have demonstrated across the nation how big a problem this is. So it's with a great pleasure that I introduce Richard Burrow. He is the Chief Government Relations Officer for the Emergency Nurses Association. They're a 44,000 member group. Richard actually has done a tremendous amount of work with them and is very experienced as being in government and has really been championing their cause. Prior to working for the ENA, he was the chief of staff of one of our congressmen here from California, Elton Gallegly. During his tenure, over 27 bills were enacted and over $140 million obtained for programs and projects. Richard has an advanced business degree, a JD from Albany Law School. So I can't think of anybody who has a better background in understanding and being able to communicate this issue to us as a representative of our emergency nurses, who are really a lightning rod for so many of these workplace violence issues, be they physical, sexual, emotional, verbal, either internally or externally from patients. And Richard, we're really delighted to have you come and speak with us today.
Thank you, Chuck. I appreciate that introduction, and I'm glad to be able to participate in this webinar on workplace violence. As Chuck mentioned, I am the Chief Government Relations Officer for ENA, the Emergency Nurses Association. We are actually headquartered in the Chicago metropolitan area, but I am based, of course, in Washington, D.C. ENA is the largest professional healthcare organization dedicated to improving emergency nursing care. As Chuck mentioned, we have 44,000 members, not only in the United States, but in dozens of countries throughout the world. And without a doubt, our number one public policy issue is workplace violence. It's not even close. And not only is it an extremely important government relations priority, but among all issues that impact the overall practice of emergency nursing for our members, there is probably no problem more important than violent assaults and batteries in the workplace. It's something that all our members have experienced at one point in their career. In terms of today's presentation, I first wanted to go through some of the research findings related to workplace violence in the healthcare setting. Then I will focus on the detrimental impact of violence specifically to emergency departments and emergency nurses. Lastly, I'm going to discuss the legislative initiatives at the federal and state levels, as well as education and training, which ENA is conducting in an attempt to reduce and respond to violent attacks on nurses and other healthcare professionals that take place far too often. All right, so let's get right into the research. There's a lot of research on this issue, but probably the seminal study is the GAO report, Government Accountability Office report from 2016. The main finding of the report, and I want to preface it by saying it was limited to private sector employees, so it excluded the VA and other public sector employees, but it really gets a good snapshot as to the magnitude of the problem. The report found that healthcare workers in inpatient facilities sustain injuries caused by workplace violence at 5 times the rate for U.S. workers overall. The most common type, as you would expect, include hitting, kicking, and beatings. And in 2011, according to GAO, they ranged from 22,000 to 81,000 incidents of workplace violence in healthcare facilities. Those were non-fatal injuries. That number, again, it's a wide breadth, but it's related to the fact that reporting or underreporting is rife in the healthcare sector. And I know GAO is conducting additional studies to really home in on a more precise figure in terms of total number of incidents. Okay, this next slide talks about some other findings. In addition to the GAO report, OSHA back in 2015 found that healthcare workers account for 20% of workplace injuries. That's in line with what you'd expect given the number of employees in healthcare in relation to our overall economy. But healthcare workers accounted for 50% of all victims of assault. And the Bureau of Labor Statistics found that workers in the healthcare and social assistance industry had the highest rate of non-fatal injuries of any industry in the United States at 8.2 cases per 10,000. We all know that it takes a terrible human toll on workers, but it also has substantial economic consequences. American Hospital Association did a survey back in 2016, $2.7 billion negative impact to our economy and to hospitals and health systems, including $1.1 billion expended in security and training. And then, as you can see, a lot of $852 million in unreimbursed medical care for victims, $425 million in staff and other costs related to violence, and $280 million is spent annually on preparedness and prevention. So that's the problem with the overall healthcare industry and hospitals in general. It is especially problematic when you talk about emergency departments. As you know, under the Federal Emergency Medical Treatment and Labor Act, known as EMTALA, which was passed and enacted in 1986, hospital emergency departments are required to medically screen every patient who seeks emergency care and then to stabilize or transfer patients with medical emergencies. This is regardless, obviously, of ability to pay or insurance status. So in effect, emergency departments are accessible 24/7, and they're accessible for any person seeking medical treatment. On top of this, the very nature of care provided in EDs often leads to highly stressful situations, not only for patients, but for family members and other visitors. This is further exacerbated by the problem of boarding of patients in the ED, which is a growing problem. There's many reasons why boarding has become so much worse in emergency departments in recent years, but certainly the opioid crisis and the lack of treatment options in communities for mental health patients is part of the reason. Mental health patients not only utilize more resources than other patients, but they are forced to wait, sometimes for days, until a bed in an inpatient facility becomes available. And in fact, ENA conducted research a couple of years back that found that the average stay, this is the average stay in an ED for a behavioral health patient, is 18 hours versus only 4 hours for all other types of patients. So this leads to emergency nurses being victimized at very high rates in emergency departments. They have the highest rate of physical assault of all nurses, according to numerous studies. That study was from the Journal of Emergency Nursing in 2002 that found the high rate of physical assault. And workers in emergency departments experience violence at least 6 times per year. And underreporting is also a very common problem. We'll get into the reasons why in the next slide. But there's these statistics 6 times per year are viewed as very conservative because many emergency nurses simply do not report and follow up on incidents of violence. So given that, it has a real detrimental impact on ENA members and all emergency nurses. They suffer from higher rates of acute stress than any other nursing group, and 94% report at least one PTSD symptom, and 17% are probably diagnosable as having PTSD. 1/3 of emergency nurses, according to surveys that we've done and have been conducted by various publications, have found that emergency nurses would consider leaving the profession due solely to workplace violence. So why are violent incidents underreported? What are the barriers to reporting? First and foremost, in some instances, this is not universal. It really varies by hospital and healthcare system, but there's often a lack of support from employers in terms of reporting workplace violence. There's also a very inconsistent response from law enforcement. It really depends on the jurisdiction in terms of whether police and district attorneys are willing to prosecute cases of violence assault and batteries in the workplace. There's also internally within nurses and other healthcare providers, there's a culture of acceptance that this is part of the job, this is the way it's always been, and that also prevents reporting of incidents. And lastly, it's difficult to track trends and data on this issue. Every jurisdiction, every state has different reporting requirements. Every hospital has varying reporting requirements in terms of workplace violence, and that inhibits good data on how many incidents and the type of injuries sustained by nurses and other healthcare professionals. So we as an organization have really moved forward on trying to reduce workplace violence in several ways. One is that we are really working toward legislation to both prevent and better respond to incidents of workplace violence. And in our states, our members are working to raise awareness not only legislatively by outreaching to legislators, but we also are meeting regularly with law enforcement agencies and also talking to the general public about this problem. Legislatively, we are pushing to make assaults on healthcare workers, especially those who work in emergency departments, a felony. The problem is in many states, if you assault or batter an EMS professional, or certainly a firefighter, or a police officer, it's a very high criminal penalty, almost always a felony. That's not always the case for attacking and battering an emergency nurse or other hospital employee. So we are working to raise the penalty in the state level from misdemeanor to felony for assaults on healthcare workers in hospitals. We are up to 31 states that have enacted felony laws at the state level, with the most recent being South Dakota in 2018, passing a law to make it a felony for assaulting an emergency nurse and other emergency healthcare providers. In addition, we are urging lawmakers to enact laws to seek to prevent violence from occurring in the first place. The goal of these laws is to prevent workplace violence from occurring and ensuring the safety of patients and workers. However, unfortunately, only 9 states approximately have comprehensive workplace violence prevention laws, so it's a much tougher road for us to pursue than felony laws, but we are pushing very aggressively to implement these prevention laws in numerous states. And just recently, California and Oregon have passed laws and enacted laws to prevent workplace violence and mitigating the effects of workplace violence in hospitals. At the federal level, we are really working very aggressively on a number of fronts. OSHA back in 2016 convened a meeting of stakeholders on the issue of workplace violence. They then initiated a rulemaking process with the goal of implementing new regulations designed to reduce violence in the healthcare and social service setting. We submitted a comment letter and testified in front of OSHA. However, there's been little movement in the last several years on these regulations within the Department of Labor and within OSHA. So we are now partnering with other healthcare organizations here in Washington, and we are actively supporting a federal bill that would require healthcare facilities to develop violence prevention plans. In the House and in the Senate, there are 2 bills pending. They're almost identical, H.R. 1309 and S. 851. The main provision of these bills is to require healthcare employers, primarily hospitals and outpatient clinics, to develop and implement a comprehensive workplace violence plan in their facility. In developing these plans, the healthcare employer needs to develop processes to identify and respond to risk that make settings vulnerable to violence, implement protocols to document and investigate violence, create an environment, very importantly, create an environment that supports employees who report incidents of violence, including whistleblower protection provisions, and ensure that employees are appropriately trained in identifying and addressing hazards that may lead to more violence. So HR 1309 was introduced by Representative Joe Courtney of the state of Connecticut, and it has already passed the House Education and Labor Committee on a 26-18 vote on June 11th. We are now urging the full House of Representatives to consider and vote on HR 1309. The Senate, on the other hand, has not taken any action on their version of the bill, S-851. That bill is sponsored by Senator Tammy Baldwin of Wisconsin. Both bills have received a lot of support. HR 1309, by last count, has 213 co-sponsors. That's almost half of all members of Congress in the House as a co-sponsor of that bill. That includes 6 Republicans, and the rest are all Democrats. S-851, the Senate version, has 21 co-sponsors. However, all of them to date are Democratic co-sponsors. We are working very hard to get Republicans to sign on to that bill and become co-sponsors. So, besides our legislative initiatives and our advocacy push, ENA as an organization is also working to better educate our 44,000 members on how to combat workplace violence. Our website includes our position statement and research on this problem. We also have developed a course on workplace violence. It's a 2-hour interactive online course designed for nurses, managers, and staff who work in emergency care settings. It was launched in 2015 and modified earlier this year. In all, 9,000 individuals have already taken this workplace violence course. Participants who take the course learn how to recognize all types of violence and risk factors, apply prompt responses, implement organizational prevention strategies, and report and analyze patterns of violence in the workplace. And lastly, we have a toolkit, which is also found on our website, which was prepared in collaboration with the American Association of Nurse Leadership, that provides a comprehensive framework to systematically reduce patient, family, and lateral violence in the hospital setting. So that concludes my remarks, and I will turn it back to Chuck Denham. Thank you.
Thank you so much. I really, really appreciate what a great job and your overview of the topics, and great to bring up the issues that are at play. I think there's substantial research there that we really need to go back to as we present our cases in organizations. So, Richard, rather than fielding questions now, what we'll do is I'll introduce Vicki King, who will speak by recording, and Chief Bill Adcox, her leader at MD Anderson Cancer Center and the University of Texas Health Science Center. So I'll start off with Chief Adcox, because he's the one with us live. Chief, we really appreciate you being here to comment and supplement what Vicki will report. Vicki's got a terrific presentation, which we recorded. She's actually giving a speech today and was able to be here live, but we recorded it, and she's done a great job of really getting into the meat and the tactical areas of this daunting problem. So Chief Adcox has 37 years in municipal and campus policing. He is the chief of police and the chief security officer at the University of Texas MD Anderson Cancer Center and the University of Texas Health Science Center. Congratulations, Chief, and Vicki, on again being #1 in U.S. News and World Report rankings of the best cancer centers. And also, Chief Adcox has had numerous awards as being recognized as one of our true leaders in security in healthcare organizations. It's a great pleasure to work with him because he's also a co-leader of the MedTech program with Dr. Greg Boats, who's not on today, is covering ICU. And Chief Adcox, along with Vicki's assistance, is one of the pioneers of threat safety science, this new discipline of addressing invisible and visible threats. And he'll be leading a global collaborative actually with our world's leading hospitals on emerging threats. Vicki, who's about to speak, is the assistant chief of police at the University of Texas Police Department in Houston with Chief Adcox. She's had a 30-year career, 27 years with the Houston Police Department. She rose to assistant chief there, earning master's degrees in criminal justice. She was chief of detectives, tactical support commander. She was the director of forensic services and oversaw some of the most high-profile cases. She's also worked very closely with Secret Service and was the emissary for the Saudi royal family, and she has headed up at MD Anderson the threat assessment unit. So she has really undertaken a multidisciplinary approach, and we will start her recording now, and I'll be advancing her slides.
Oh, thank you so much. That was a very kind introduction. And I wanted to take some time today to share with our audience. I know in the framework of the nation and all the concerns about active shooters and workplace violence, I thought that this would be a good opportunity for us to talk about some things that are specifically related to the healthcare industry and our challenges. And there are some great strategic approaches to workplace violence. So we're going to spend a few minutes today talking about those challenges and some of the approaches that have been proven to be very effective. We're not going to be able to make everyone threat assessment professionals in the short time that we had to share today, but what we wanted to accomplish is introduce these principles to the audience and to let Dr. Denham know if there's more information that you'd like or a specific subject matter you'd like for us to drill down on. We could certainly provide that information either as an addendum to this presentation or maybe a future presentation if time should allow. So one of the things that we wanted to cover is that we all are aware that the healthcare industry is an extremely high-stress environment. Emotionally charged people are coming in at sometimes the worst parts of their life. There's also that issue of ebb and flow of people. It's not just our patients and our visitors, but our messages sometimes get lost in the turnover of faculty, staff, and so the message needs to be a consistent cadence. We need to ensure that the culture of our organization reinforces workplace safety. Of course, we're all governed by regulations, not just HIPAA, but also CMS. Many of our institutions are Joint Commission accredited. And of course, OSHA now is moving more and more into the mainstream of our hospitals. Some hospitals, such as state hospitals, are not required to follow OSHA guidelines, but that situation is about to change. So when we start to look at the workplace violence, this is a national focus. And this week of all weeks, in the last 2 weeks, there has been such a tremendous flow of information and energy moving around our active shooter events in Dayton, Walmart. There was even an event at another Walmart last week where mentally disturbed individuals are now taking long guns and weapons into public spaces. And our hospitals are probably one of our most vulnerable areas. So the question remains, how do we advance the workplace safety? How do we develop a threat assessment, a risk mitigation ability within our own environment? So we have a window of opportunity to address some of these issues. So we can see the cadence is increasing. When we start to look at the private sector healthcare workers, they're 3 times as likely to suffer a lost workday injury. And you can see this. This is information, unfortunately, it's a little dated 2015, but the cadence, you can see how we're trending upward. Also in non-fatal injuries, there's also a rise in healthcare workers. Again, our nurses and nurse assistants are spiraling up and in an alarming trend. And then, of course, workplace violence is also been identified as the leading cause of fatal occupational injuries among our healthcare workers. These are 2015 statistics. Now, we're all focused right now on the active shooter. The FBI defines this active shooter event very narrowly. It's one or more individuals actively engaged in killing or attempting to kill people in a populated area, mostly a public space, using one or more firearms. And so when we start to look at the trends, the first FBI report on active shooter events really looked at the time frame of 2000 to 2013. And you can see in healthcare facilities, 4 out of 160 events in this 13-year time frame occurred in healthcare institutions. And we know that the casualties were 10 killed and 10 wounded, and you can see the involved centers. Then the FBI in 2016 and 2017, there was a gap there from 2014 to 2016, but the FBI put out a new report that looked at just 2016 and 2017, and look at the cases. Now we're 4 of 50 with 7 killed and 8 wounded, and you see the hospitals there. And then in 2018, they published their active shooter report for 2018, and you see it's about the same ratio, 2 of 27 killings in healthcare facilities with 2 killed and 2 wounded. So what do we do? The active shooters, these active shooter events, they're certainly driving the conversation right now, nationally, internationally, but these only represent a very small fraction of the workplace violence incidents in healthcare. We did our own survey here in 2014, and we found, just using open source information, that in 2014 there were 55 different hospital shootings, 3 of them in the Houston area, which is where we work, and with 39 people killed, 18 wounded. That's catastrophic. So when we look at the standard of care, we're governed by CMS standards, and CMS standard 482.13 says that a patient has a right to receive care in a safe setting. And when hospitals deviate from this standard of care, their CMS funding becomes in jeopardy. So a hospital must also comply with 482.15, and that makes all applicable federal, state, and local emergency preparedness requirements a mandate. So if a catastrophic event should occur, such as an active shooter event, the hospital must have a comprehensive emergency preparedness program, and this has to meet the requirements of the section, which means that you have to be able to do the incident command in your hospital and manage these events according to national standards. Other hospitals have Joint Commission accreditation, and the Joint Commission is regularly putting out information regarding patient care, patient safety. Most recently were risk of suicides that we talked about, but Quick Safety Tip 47 talked about de-escalation in healthcare. Quick Safety Tip number 5 talked about preventing violence and criminal acts. But the typical event, alert number 59, focused directly on the physical and verbal violence against healthcare workers. So by all means, you need to direct your hospital leadership and yourself to these very helpful documents that help outline what the standards are under the Joint Commission accreditation. But I want to point you out to OSHA. And OSHA is now beginning to enter the conversation in a much larger way. OSHA has produced a workplace violence prevention for healthcare and social service workers. And they have gone to the U.S. legislature to and under a bill that has been proposed, number 1309, this bill has 42 bipartisan co-sponsors, and it calls on OSHA to issue a standard requiring employers in healthcare and social services industries to develop and implement workplace violence prevention plans that are designed to protect our employees, our nurses, our physicians, our social workers, emergency responders, all of our caregivers. And if you're wondering what that document looks like, the building blocks for developing an effective program, OSHA has published this document, which is really our guidepost. It talks about management commitment and employee participation. you need to do a worksite analysis. How good are you at doing what you need to do? Develop your hazard prevention and control, safety and health training, and then record keeping and program evaluation. What this bill is proposing is that not later than a year from the date of the enactment of the Act, the Secretary of Labor will promulgate a final standard on workplace violence prevention. And it's going to require certain employees in healthcare and social service sectors, they have to develop a plan, a comprehensive workplace violence plan to protect healthcare workers. And this plan, at a minimum, should be based on these OSHA guidelines that were published in 2015. So you have your guidepost. Now, one of the things that I want to explore with you for just a few minutes is the difference between targeted violence and effective violence. Effective violence is what we all know. This is anyone who's driven on a freeway has experienced effective violence. So you're traveling on the freeway, someone cuts you off, they put you and your family in danger, and for a split second, you see red. You're angry, you want to lash out. Now, all of us who drive get that under control very quickly, but it's an intense autonomic arousal. It's an instinctive experience of emotion, a flood of emotion that you're going to react to that violence. And your goal in that moment is threat reduction. And this is very time limited. It burns itself out very quickly. And you've seen, folks who are posturing, getting ready to fight after a heightened emotional experience, but you're able to diffuse that very quickly. So when you're developing your workplace violence plan, the effective violence piece of that plan deals with de-escalation. It focuses on tamping down, building a little space, trying to buy some time until that person is able to get control of their emotions to bring the atmosphere down. There's a different type of violence, which is called targeted violence. And this was developed, these models by Reed Malloy, who is a forensic psychiatrist, and he works with the FBI's behavioral profiling unit. He's a master of this. And what he talks about is targeted violence is that cold-blooded killer, the ones that you see in these active shooter events. No conscience or emotion. The events are planned and purposeful, and you may not see an imminent threat because it comes at you from it's seemingly nowhere. There are different types of goals that these killers engage in. Some of them want revenge. Some of them want to promote a specific ideology, but they don't displace their target. Unlike effective violence, people lash out at the closest thing to them. A targeted violence is very specific and goal-oriented. It may have a type of person that it wants to affect. It may have an impact that it wants to make, but their goal is very specific. And the dangerous thing about this is there's no time-limited sequence. I have one targeted violence event that spanned 21 years from the point of grievance to the point of violence. And that's a very scary thing. You can see in their ritualistic behavior, their planning, there is what we call leakage. There are opportunities for intervention and identification. So what I want to do is I want to walk through a couple of cases very quickly. This case is St. Joseph's Hospital here in Houston. And I have immense love and respect for my brothers and sisters at St. Joseph's Hospital. St. Joseph's Hospital is embedded in the downtown area. In fact, it's of the city of Houston. It's the only hospital in downtown Houston. And they serve an underserved population. They serve our homeless and our indigent patients freely. St. Joseph's Hospital is also where I was born, so I have a great love for this hospital. But their response to a specific incident involving a psychotic patient almost resulted in their loss of CMS funding. And as we all know, a hospital who serves underserved populations, if they cannot receive CMS funds, they may as well become a hotel because it's a catastrophic event. So this information was obtained through the Harris County Court records, and it occurred in 2015. Alan Christopher Payon, he pronounces his last name Payon, was experiencing a psychotic episode. He was having delusional thoughts, mania, thought people were following him. He tried to, he believed that people were in his apartment, so he escaped, and he began driving his car. He went to the closest hospital he could remember the location of, and that was St. Joseph's Hospital. And while en route, he crashed into several parked cars, and his car finally came to a stop when it crashed into the St. Joseph's Medical Center building. And the hospital staff admitted him into the emergency room. He was treated and admitted for overnight observation. So the next day, he had stabilized somewhat. The hospital administration or the care team had agreed to his discharge. They had contacted his parents, and told him that they were preparing his discharge paperwork. So his nurse went to his room, told him to take a shower and to get dressed and prepare for discharge. So he does that, and while he's in the shower, his mania begins to return. His mania, his psychosis, his anxiety begins to come. And so he, in his delusional state, believes that he is now going to be on television. He is going to be interviewed, and because he's going to be interviewed, he needs a suit. So he walks out of his hospital room, and he goes to the nurse's station, and he tells the nurse he needs a suit to wear to be on TV. Now, he only arrived in jeans and a shirt. That's all the clothing he had. He is stark naked, and so the nurse redirects him back to his room and tells him to wait on his parents. When he goes back to his room, he's looking for a suit, can't find it, and he returns to the nurse's station 3 or 4 times. So the nurse contacts the security, and the security at that time are off-duty Houston police officers working second jobs. And so you have 2 officers of different skill sets that respond. You have a veteran officer of many years of service, and then you have a younger officer. You have Officer Ortega, the older officer, and Officer Law, the younger officer. The interesting piece about this is the younger officer has been trained in de-escalation skills. He's been trained in mental health, dealing with mental health consumers. The older officer has not. He's not received the same type of training. And so they respond. The nurse at the nurse's station asks them to please go and tell Mr. Payon that he can't come out into the nurse's area naked. She said that he hasn't been combative, he hasn't been volatile, but he needs to be redirected. So the officers enter the room, and they see Mr. Payon fiddling, they see Alan fiddling with the oxygen valves. And so Officer Ortega asked him, please step away, and he begins his command voices and tells him to put on his clothes and then get back into bed. Alan doesn't respond. Officer Law, who's been trained in de-escalation skills, knows that when someone's in a psychotic episode, one of the best ways to reach out to that person is to call them by name. So he steps back out of the room in order to learn Alan's name so that he can begin to de-escalate the situation. Officer Ortega is left alone. Now, Officer Ortega has not been trained and does not realize that Alan is paranoid. He thought people were out to get him, and he had slipped back into this delusional state. And Officer Ortega, trying to get his attention, claps his hands together loudly and tells Alan, get dressed. They're coming to get you. Well, that obviously plays into the delusional episode that Alan's having and caused a reaction. Now, the stories diverge here a little bit. Officer Ortega says that Alan charged him and pushed him in the chest. Alan has a recollection that Officer Ortega moved toward him in a threatening manner, which caused him to retaliate. Officer Ortega goes down to the floor. When he hits the floor, he says he heard his head split, and he began screaming to Officer Law to help. Officer Law returns to the room. Now, remember, Alan is completely naked, and he is sweat-soaked, as many of our people in crisis tend to get, and he is slippery. And the two of them are grappling with him, trying to get control. Officer Ortega was struck in the head, and he reports that he started to black out. Alan placed Officer Law in a headlock and began beating him about the head. Officer Ortega regained some of his senses, jumped up to help his partner, and reportedly knocked Alan off of Officer Law's back. At that time, Officer Ortega responds that he heard that Alan said, "Now I'm really going to hurt you. I'm going to hurt you bad." Officer Law, who's down on the ground, reaches and discharges his taser, striking Alan. Officer Ortega simultaneously reaches for his sidearm and shoots Alan one time in the chest. Officer Ortega is so overcome, he's injured, he staggers out of the room, and he faints. Both officers suffered concussions from the incident, and Alan is now fighting for his life. He's rushed to surgery, and he survives. And this is one of those cases where the outcome can be best described as lawful but awful. And the fallout of this was extreme. This is an article that was written. The publicity, negative publicity, cannot be underestimated. You see the hospital bore the brunt of this when the hospital fires the bullet, not the officers. So you have your brand impact, you have profitability, you have staff morale, you have staff retention. CMS charged and had a finding that patients were in imminent jeopardy because of the violation of patient rights, poor training and handling of aggressive or disoriented patients. This information was directly translated into a lawsuit. And the lawsuit charged not only the hospital, but the officers were sued in their individual capacity. And they said that drawing on CMS's findings that failure to act responsibly in the hiring and training of security personnel and off-duty police, and failing to establish proper policies and procedures, and of course malpractice. The case is still in litigation and will be probably for quite some time. The point of this is that there is an alternative. When many hospitals have to use this off-duty security model, but it doesn't alleviate the responsibility to make sure that the off-duty officers that you have are properly trained. Now, we have an officer skill set inventory that we use for our people. It includes crisis negotiations, rapid response, investigation, slow things down, a threat management approach, and education and community outreach. We train our officers to get this fully converged skill set so that when a critical incident occurs, we can slow things down. And just to illustrate the difference, and we can't say that every outcome will be a positive one. That's not what we're saying. What we want to do is give our security personnel, our police officers, and our staff the skills to get them to the best chance for a positive outcome. Now, we had a somewhat similar situation at MD Anderson. We had a patient who was suffering from brain cancer. He was nearing end of life. He was a big man. They had put a sitter in his room to protect him from a fall risk and alert staff if he tried to get out of bed. This event occurred over the weekend. He was struggling with pain management. Obviously, his disease progression was advanced. He was delusional and psychotic. He began to have paranoid episodes, and he didn't have family with him during this period. What happened was he started to get up, tried to get out of bed, and as he did, the sitter approached him and said, "Oh, sir, please, let me get someone to help you." And in his delusional state, the young woman who approached him was a threat. He thought she was trying to kill him. He reached for his dinner tray. He extracted a knife. He grabbed her in a headlock, put the knife to her throat, and said, "This is not going to end well for you." Of course, she screams, the care team responds, the police are called, and two University of Texas police officers respond to the scene. One of our officers is an expert shot, but it should not be the first tool you pull out of your tool belt. And so he begins to engage the suspect in a conversation, but he approaches it as, "We're the police. We're here to help you. Let me help you." And he says, "This woman's trying to kill me. No, nobody's going to hurt you now. We're here to help you. We're here for you. Let's put that down. Let's slow things down." Keeping our patient in crisis talking. Actually talk to the patient, the patient, and in his delusional state, he said, "Well, how do I know that you're the police?" Now, understand that these officers are in full uniform, and so the officer does something. He reaches up, he removes his badge from his uniform, and hands it to the patient. The patient now has something tactile, something substantial. He now realizes this is a police officer he's talking to. He releases the sitter, and they are able to get him back into bed and manage his issues. The patient died 3 days later. Now, had this gone the traditional route and commands and really tamping up the situation, what we're concerned about is that it would have reached a volatile state, and the headline would have read, "MD Anderson shoots cancer patient." We can't have that. We need to engage in active listening. The empathy that was showed, the rapport that was built, was able to influence and change this patient's behavior and give us an opportunity to help him. And it was a positive outcome. We believe that our organizational health model, that threat management sustains organizational health and achieves the workplace safety goal of preventing violence through early identification and swift application of intervention strategies. It's a prevention model, not a prosecution model. So we are trying to experiment with different skill sets. We make sure that our team has the tools necessary to de-escalate a situation. Doesn't mean we're going to be 100% successful every time, but it is an opportunity for us to work through these issues. We use structured judgment tools that have been validated. The Waiver 21 is our workplace assessment of risk violence, and these are designed for our targeted violence cases. The NABITA risk assessment tool, it has both a self-harm scale as well as a violence scale. Our stalking assessment and management tool is for our stalkers. Domestic violence is one of the biggest threats to workplace safety, and utilize this structured judgment tool to assist. And then finally, sexual violence, our risk assessment for that tool, used a little bit later, less frequently than the others. So when we talk about the impact, we wanted just to visit real quickly about some of the folks that have lost their lives to workplace violence incidents. April 4th, Baton Rouge General Hospital. We have Jesse Guillory, a patient who presented. He was a problematic patient for a number of years, a frequent flyer, and he engaged in some sort of interaction with hospital staff. Our lead nurse, Lynn Truxillo, she tried to intercede. Lynn got between Jesse and the other nurse and was thrown to the ground. She suffered what appeared to be relatively minor injuries, but she also tore her ACL. Now, to tell you the type of person Lynn was, Lynn actually finished her shift and then sought out medical treatment. And this event occurred just this past April. On April 11th, she went in to surgery to repair her torn ACL. It was repaired. She went home that night. She began having trouble breathing. She had developed a blood clot, and she died from a pulmonary edema. Tragic case. Jesse was charged with second-degree murder, and that case is still pending. There are other cases. Dr. Goodyear, he was East Jefferson Hospital. He was killed by a patient who was upset over a diagnosis. We have Dr. Tamara O'Neill at Mercy General Hospital. She was killed by her fiance in the parking lot of the hospital. Then he fled into the hospital, resulting in the death of a police officer, Tamara himself, and a pharmacy tech who, so tragic, 24 years old. And then, of course, Dr. Mark Halkanek, who was just killed, it says 2019, I'm sorry, it was 2018, last year, July 20, 2018, in the Texas Medical Center. He was the one, George Bush's cardiologist, killed by the son of a patient who died during a procedure. The time from the grievance to the killing was 21 years on that targeted violence event. The suspect, when he was arrested, at the time of his arrest, when officers rushed in to try and take him into custody, he killed himself. One of the things that we found when we went in is that he had dossiers on 89 other healthcare workers. Now, whether or not it was his intent to go beyond the killing of Mark Halkanek and endanger the lives of others can't be known. But certainly that targeted violence event could have been much worse. So this is the threat management process. How do you manage these cases? You've got to take these reports. We use a multidisciplinary team to evaluate the threat and to develop intervention strategies. Our threat management unit that works 24/7, 365, they're the information getters. They take these reports, this information, and they interview people. They interview the suspect. They do the risk assessments on our targets of our cases, and they feed that information back to our multidisciplinary team. And out of that come recommendations on how to best manage the threat. And sometimes that's a law enforcement intervention, but most of the time it's using other interdisciplinary team members to create what we call a soft landing. So prevention begins with assessment. You can't know or assess those things that you don't know about. You have to, in order to implement a threat assessment program, you need to gain institutional support and buy-in. You do that building your business case. Once you establish the threat risk protocol, you need to have a reporting mechanism. It's not enough just to have the mantra of see something, say something. You have to know what to look for and to whom to report. So the centralized reporting for this triage, assessing the threat, and allocating the requisite resources. This all begins, you can only do this if you have a culture of safety in your organization, and that begins with training and educating your community. So we've developed a scaled model for threat mitigation. The phase one, you need to do a capabilities assessment. You need to train your people in de-escalation, threat assessment, structured judgment tools, your emergency response protocols. The most important part of this is information sharing. Many times we set up these silos and we can't break them down. Establish that multidisciplinary behavioral intervention team built on the same model as that which was developed after Virginia Tech. More minds in the mix help you develop a better plan. And then, of course, policy revisions to support those. The phase 2 is to establish your threat management team, develop your triage capabilities, and manage your intervention strategies. You develop your monitoring protocols because many times these cases last for a very long time, and develop information streams that are independent of staff reports. That means that you don't want to have any stovepiping. You've got to have multiple information streams coming in to one central location. And then your mature program is going to use performance metrics to drive that process improvement, establish protective threat detection resources. You're going to drive community engagement for risk reduction and create that culture of caring, respect, and risk mitigation. So you have your threats and risks, you enter into the prevention. We utilize the combined protection model, an agile and adaptive risk management posture. We have community engagement, and the driving force is that constant performance improvement for our preparedness and our protection. And this way we're helping achieve the very best outcomes. I know that's a lot of information I've thrown in, but I know I wanted to have a broad breadth of information so that those out there in the audience can redirect their questions to Chuck and get more information about specific areas of this very broad approach to threat and risk management. Chuck?
Well, thank you so much. And as always, Vicki, you provide a wealth of information that is so practical, tactical, and yet is really grounded in critical systems thinking. And so we appreciate it so much. We'll be posting additional resources on the web, but we thank you so much, and we thank you for pre-recording this in light of the fact that you're presenting during our webinar. So thank you very much, Vicki. You're tremendous.
Thank you, Chuck.
So now what I'd like to do is draw your attention to the survey questions. And if you'd like to have another webinar on workplace violence, I'm going to ask Kyle to put up our survey right now, and you can respond and give us a 10 or 9 or a 10 if you'd like to have more and a drill down in workplace violence as it applies to both patient safety and caregiver safety, and then the specific topics that you would like to have addressed in the workplace violence free text entry page there, and that would be great. And I'm going to ask Chief Adcox, we're at 17 minutes after the hour, right on time, and we really love the comprehensiveness that you and Vicki apply to this. Bill, would you please just compliment any of these things before we go back to Richard for his comments now that Vicki's spoken, and then we'll go to Arlene. Bill?
Well, thank you, Chuck. Really some great information. I want to thank Vicki and Richard for the wonderful presentations. I just want to remind everybody, kind of recap, that there's such a high level of workplace violence in the healthcare setting. I think studies show between 4 and 5 times that of other industries. But also significant is the fact that virtually all the studies show that there's a serious or significant amount of underreporting of workplace violence, as well as, believe it or not, healthcare workers believe that it's their that they should continue to accept that because it's part of their jobs, and in fact it really shouldn't be. Bottom line is early identification and response to low-level behaviors of concern is very critical to prevention. So if we establish a culture of safety that encourages all of our employees to report concerns as they come up or as they emerge, and not wait till it becomes serious or it escalates, that's where we're going to have our success. So by using a systems approach and using the 4 Ps, which we do, the prevention, preparedness, protection, and of course performance improvement, you're going to be able to have some success. The last thing I'd like to do is just remind everybody that if you're in a hospital, it is highly recommended that you do put together your threat management program. And in that, I think Vicki talked very strongly about having your multidisciplinary or your behavioral intervention teams. But I want to stress that if you do that, there's some components that I highly recommend. And number one is that you do have a threat assessment unit or threat assessment team as part of that multidisciplinary team. Number two is that you have a clinical psychologist part of that, and there's a lot of reasons for that and expertise that he or she brings. And lastly, always utilize structured assessment tools. These structured judgment tools are very critical, and they will protect you. In the healthcare setting, it is so advanced. If you want to talk about getting everything all the way up to, unfortunately, an active shooter, a couple things to remember is that an active shooter motives in the healthcare setting it's usually more personal, generally targeted and very focused. And there's really no studies around that will show you that violence is spontaneous. People just don't snap. And so there's going to be a reason for it. In healthcare settings, again, it's usually targeted if it's at the worst state. So again, I want to stress that early identification is critical to low-level behaviors of concern. So if you train everybody, you know what to look for. You have early intervention, and the intervention is for the purposes of helping people. Then you're going to have your greatest success of preventing abuse. Have a safety culture that encourages people to report, and that you don't accept it as being part of your job. And I think we'll have greater success. But great work by everybody, and I'll be available if there's any questions.
Great. Thank you, Bill. And I'm going to draw everybody's attention to the second question, just so we make sure to finish the survey. Our next webinar next month is on in-flight emergencies for caregivers, and the title is Good Samaritans at Altitude. And I think many of our emergency medicine nurses that are on flight, so will probably be called on to be helpers there. So we have a terrific program for next month. Want to make sure that you put in topics. If you want to support being invited to that webinar, please do, and also the topics that you'd like to have covered. And then coming back to you, Richard, the third question is, we're asking our audience, give it a 9 or a 10 if you want more on the emergency department, not only nurses, but the whole department safety issues. We think this is just a critical area and the topics that you'd like to address. So, Richard, back to you now that you've heard Vicki and you've heard Bill Adcox comments. What would you like to add or complement or other thoughts that you might want to reinforce?
No, my only initial thought, Chuck, is the presentations that I heard were just fantastic. And there's so much consistency between what Vicki said and what I was saying in terms of you need a comprehensive approach. You need to work, at least from my perspective, legislatively. You have to work on legislation that prevents and increases your ability to respond to violent incidents. You have to have consequences on the back end for perpetrators of violence and assaults and batteries in the workplace. And you need to raise awareness so law enforcement is in sync with lawmakers in terms of making sure they respond appropriately and take any incident of violence seriously. So I think the need for a comprehensive legislative approach which dovetails into a law enforcement approach is the only way you're really going to make a dent in this problem, which we have seen growing and growing over the last 5-6 years.
Great. Thank you, Richard. I want to swing back to Arlene, having been in an environment where there was workplace violence, not necessarily physical, sometimes physical to the patients, but also this emotional and verbal, and the manipulation by those in greater power over those workers that are the nurses or the caregivers or the staff that are supporting. Arlene, thoughts there before we go back through everybody one more time?
Well, with my personal experience, a caregiver, too, has to be confident if they do see anything that they suspect that may put lives in danger, that they will not be retaliated against if they bring it up to their superiors. So I think that's very important, too, to feel comfortable enough to prevent a crisis before it happens by being open and not fear retaliation. And I want to say another thing. I'm glad that there's all these steps to prevent maybe a patient in crisis or their family who become in crisis, that there's a system set up to deal with that. and a system that will hopefully bring the best outcome where nobody does get hurt. But you have to think about those things before it happens. So I'm glad the presentation was wonderful, and I'm glad to see that there's a lot of thought and people are working on this, and hopefully in the future we could prevent a lot more loss of life. Thank you.
Well, thank you. And I know, Bill, you're leading across multiple organizations in evaluation and best practices and emerging threats. And this is one of those pretty interesting topics in that most leaders are unaware of the magnitude of workplace violence, which A, is much more frequent than people think, B, unreported, and C, some of them are thinking it's an emerging threat, but it's been a threat for some time. And this area of invisible and visible threats and getting kind of left of boom. You have a couple minutes to just describe this concept that came from the military of left of boom and moving upstream.
Oh, certainly. The thing to remember is that we get so focused in our jobs, and even the leaders, that we are sort of, believe it or not, we're kind of removed from a lot of the activities in our organization, and particularly anything that goes on outside of our clinic, outside of our work area. And so we may see something from occasional time and time again, but we're thinking it's just a few incidents, it's just our area. But when you take a look at crossing all these silos and gathering all this information, then you really, really will have that issue of what the real problem is, and then you can deal with the underreporting, and you can deal with this, the perception that this is my job, is to be exposed to these types of issues. Then you'll actually have an understanding of what the real problem is, because to me it's just a powder keg ready to go off at any organization. And so the left of boom premise is that you're looking at prevention. So you're looking at how do we do things in a preventative preparedness and protection arena that would prevent an incident from occurring to begin with. And that's why you're hearing a lot more about how facilities are being designed, how they have better protected areas where patients are going to be going into for treatment, panic buttons. You have a lot of different systems that are in place. So you look at the physical structure all the way to the training and awareness of the employees. Employees need to have deconfliction. It doesn't matter if it's CPI, if it's MOAB, or whatever the programs are. There's many of them out there. I think Richard mentioned a really good one that his organization has put together. Just doesn't matter. Just have people look at how do I identify a problem and how do I de-escalate if something comes in. Plus, where do you stand in a patient's room? How do you sense when something's happening? When is it time to get the assistance and the help? Having all those responses available, making sure that you're documenting things so that the next person's coming on understand if someone has been aggravated earlier. What we're actually finding is where a physician can calm someone down pretty quickly, or if they're talking to them, they treat a physician a little differently. When the physician leaves, then the patient sometimes becomes more aggravated. So there's things that we can do all the way up to having these information systems and multidisciplinary teams, having the threat assessment teams. And what I like to remind people about having a good, strong threat assessment team is because they're just facts gathered. They're 24 hours a day. They move real quickly. They have the right context. They know what information to look for. They ensure that it's impartial, it's fair, it's an objective review. They look at things from a global perspective, and I believe that they can help you get in front of these things. And again, that's left of boom. How do we get in front of a potential problem or crisis? So there's a lot of things that are here that can be done. This particular webinar and Dr. Denham's making available through TMIT here. There'll be a lot of information. There'll be the slides. There's a lot of individuals that can help everybody. We just hope that everybody does what they can, because these are scalable approaches. Some organizations have resources more than others. Some organizations have different challenges, whether you're urban or you're rural, whether you're large or you're small. But everybody can do something to get left of boom, to get out in front of these problems, and we're just very proud to be part of this webinar today to try to work on this workplace violence, because it is a problem, and in some instances it's a powder keg.
Well, thank you, Bill. Thank you so much, and thank you for the pioneering work that you all are doing regarding these emerging threats and getting upstream, this term from the military, where boom was where the IEDs were harming our soldiers, and they moved upstream to prevent these from even happening, and I think getting upstream is so critical. Richard, I'm going to just loop back to you right now and just tell us where we could go to learn more about the resources you have. And again, thank you for a great introduction to this topic, and then I'm going to go to Arlene to close us. So Richard, where can we go to learn more about the great work you guys are doing?
Sure. I mean, our website is just a font of information, www.ena.org. We have a education page. We also have pages devoted to government relations, including the Workplace Violence Prevention Bill that is currently winding its way through Congress. We expect action on that bill when we return from August recess in September in the House. So I urge everybody to get involved through their own organizations or their own hospital to advocate on behalf of those bills. They're a good first step. Nobody thinks legislation is going to solve the problem, but being able to provide resources and develop plans to mitigate and prevent violence, I think, Chuck, is certainly an important first step. So the website's got great information. We also have our workplace violence toolkit on our website for everybody to look at, as well as our position statement. There's also other organizations, including the American College of Emergency Physicians, American Nursing Association, and others that have information, resources, research findings devoted to workplace violence. They're all great source of information, as is obviously your organization, Chuck, TMIT. Just great information on the problem and how to work toward resolving that problem.
Well, thank you, Richard, and thank you for your great work in Washington. And whenever we work with you, we're just encouraged by having such honorable and smart men like you, and it goes against this negative stuff that we see in the press. So thanks for all you've done on behalf of healthcare and nurses and for us in Washington. And Chief Adcox, again, thank you so much for all your great pioneering work. Arlene, you've just been just a steadfast supporter of patient safety. Would you please close us, and we'll keep the speakers on just for a minute to see how we could do better next time. But Arlene, please close us.
Yeah, I just want to thank everyone for taking the time today to be here and to listen to these great presentations. I hope that you'll share this with others in your different organizations. And I hope, too, to see more on preventing the healthcare violence, because it's a very relevant subject today. And if we could save lives, it's very important. So thank you, Chuck, and thank you, everyone, and have a good day.
Great. Well, God bless you all. And next webinar is spectacular. I've heard Dr. Katzer speak on in-flight emergencies, and it's Good Samaritans at altitude. What those of us that are trained in healthcare can do on a commercial or a private flight when someone has a sudden cardiac arrest or a medical emergency. Just a terrific presentation, and we're honored to have him next month. So with that, we'll close today, and we hope you have a great month.